The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Here's a big welcome from Brentwood, Tennessee for the next episode of TMD Demystified. I'm Tony Urbanek. Glad to have you here, and I hope what I have to say in the next 20 minutes will be very helpful to you and your interest or practice or use in treating patients with temporomandibular joint disorder. The title and topic for today is Protocol and device are both necessary and work together. One without the other is not as effective. So when I say device, I mean the Urbanek device, and the protocol is the protocol that goes with the Urbanek device. There's a history on this. I've mentioned it many times, but today we're going to bring it all together on this one topic and this one part of this, of that the device and protocol work together. One without the other is not as effective, and that is a fact. The protocol is very simple. The device is very simple. Both of them together are very, very simple. But one without the other is not going to get you there, especially if you use the device any old way you want to, or don't follow the protocol. Again, for one of several times, and especially for those who are viewing this particular video of me for the first time, I stopped doing temporomandibular joint surgery 14 years ago after 2,000 cases and decided to see if I could figure out what nobody could figure out about this conundrum that we all call TMD. Fortunately, I did, and the method I used is well expressed on other videos, but basically, instead of reading the literature, going to congresses, listening to my colleagues, reading the textbooks of both non-surgical and surgical instructions, I decided to start wherever any good study or investigation would start in the healthcare system, and that would be with the patient. Start from the beginning without bias. I attempted by eliminating all of my biases garnered through textbooks, congresses, lectures, friends, acquaintances, colleagues. They all had biases. The general dentist had biases against surgery. The surgeons had biases against doing things non-surgical. There were biases from TMD gurus who use machinery to diagnose and treat TMD. It went on and on and went on and on for the better part of 50 years since I entered the profession of dentistry and the specialty of oral and maxillofacial surgery. Everyone agreed, almost everyone agreed, that when it came to TMD, TMJ problems, nothing worked, except those very few, what I call and stick by it, TMD gurus who use smoke and mirrors. And at very best, you give them the benefit of the doubt, try to treat symptoms only. Now, you can treat symptoms forever in many kind of different ways. I mean, for example, if the patient is having pain, you can overload them with narcotics. Is that a treatment? Yes. Is it a suggested treatment? No. Is it a treatment with significant detrimental side effects? Absolutely. But you can say, I treated the patient. Well, you didn't treat the patient correctly. And when I was a freshman in medical school, I took an oath to do no harm. I can remember it directly. We got them all together with our little white coats on and recited that pledge. So you don't want to do things that do harm, and certainly not intentionally. So the device, which does nothing more than unload the temporomandibular joint, that's what it does. It unloads the temporomandibular joint, takes the load off the joint like a set of crutches takes the load off a bad knee. If you had a bad knee and went to the orthopedic surgeon and said, I have a bad knee, it hurts all the time, what should I do? Well, he would do a very expensive workup, several $1,000s, including an MRI, some plain films, and say, you have a very, very damaged knee. You have a lot of degenerative changes. I'd recommend we doing surgery. And then if you said, no, I don't want to do surgery, what else you got? He would say, well, we can do injections for a couple of years. Every few months, 3 to 4 months, maybe we get out each injection. And then within 2 or 3 years, you'd be having symptoms again, even though we're injecting. And then we'll do surgery. And if you said, no, I don't want to do that, what else you got? He would hand you a set of crutches. Rightfully so. And he'd say, if you get on these crutches and get off your knee, I promise you, your knee pain is going to go away. And he would be correct 100% of the time. So what this device does, it unloads the joint, just like a set of crutches unloads the knee, according to a protocol. Now, I've talked many times about patient compliance, and I also need to speak on doctor compliance, because the treatment using this device and the protocol is extremely simple, extremely simple. But the protocol is that you put this thing in your mouth and you wear it 24/7, except when you eat. You can drink with it in your mouth. Coffee, tea, soup, hot fluids are fine. You can speak with it nicely in your mouth after the first few days, because after the first moment you put it in your mouth, everybody, 100% of patients want to put their tongue on it and try to talk at the same time. And they end up sounding like this. And I say, I talk funny. I go, yes, you do. And as soon as you get your tongue off your device, you're going to talk perfectly. And they do. Everybody figures it out. Some people figure it out in 2 minutes. Some people figure it out in 2 weeks. But everybody figures it out. But the short way to figure it out is to put it in your mouth and speak slowly for a couple of days. Just slow your speech down to about half speed for a few days, 2 or maybe 3 days. Your tongue will get used to it, proper positioning for S's and T's, and you'll speak perfectly. I learned that little trick from the speech pathologist when I did hundreds of cleft palate cases. Got to be really good friends with the speech pathologists. So you can speak with it in your mouth. You can swallow nicely. You can drink liquids. You just can't chew. And when you chew, when you manger, you must take it out of your mouth until you're finished, at which point you brush your teeth. You brush the device with toothbrush, toothpaste only, and put it in your mouth. That is the protocol for the first 2 months, 24/7, except when you eat, for the first 2 months. After that, almost exclusively, there are a few exceptions. There are exceptions to every rule, and there are very few. Almost everybody then is brought to the point of using it nighttime only or sleep time only, nap time, sleep time, indefinitely for the rest of your life. What is happening when you do that is when you put it in 24/7, it unloads the joint, and it takes a while for the chronic inflammation within the joint itself to start to decrease. Now, that decrease isn't always at the same rate within patients. It changes within patients for various reasons: general health, systemic health, how much they continue to brux or not, because you're not going to stop the patient from bruxing. Don't even attempt to do that. There is no on and off switch for bruxing. There is no way you can talk the patient out of bruxing, whether it be during the night or day. Obviously, they have no control at night, but even during the day, there's there's no social way to talk somebody out of bruxing their teeth. We don't even understand the mechanism for bruxing. So how can you get someone to stop bruxing if you don't even know the mechanism? All we know about bruxing is related to stress. The more stress, anxiety, and worry, the more tendency patients have to brux their teeth, clench and grind. Half the population in the country bruxes, and many of them, probably half of those, don't even know where they do it, but they do it. And not everybody who bruxes develops TMD. But the point is, we have no solution for bruxing, so that's not part of the treatment equation. But the point is, the protocol, you have to follow the protocol. And the protocol, again, is 24/7, then nighttime only the rest of your life. And the protocol needs to be understood by both doctor and patient. I tell my patients constantly, and I do still see patients 1 day a week. I see patients 1 day a week, and it's a pretty full Monday when I see patients. But I tell them that they must follow the protocol, and they need to know how it works. Half of my job is to explain to the patient what's going on so they understand it. Once they understand it, they are much more prone to follow the protocol because they see the importance of it. Again, not everyone does, and it is definitely happening when someone wants to, they hear the information, they acknowledge the information, and they go on and do it the way they want to do it. And consistently, they do not get the same quality and quantity of symptom relief that a patient who follows the protocol will get. And the 24/7 part of this is extremely important because it takes a little time for the chronic inflammation to die down completely to get to the point where then we can go to nighttime or sleep time only to keep the inflammation at bay. And there are things that the patient needs to know about that. 85% of our patients, in our experience with over 5,000 patients treated successfully, 85% of those patients, nighttime only, that's all they have to do, and 15% find they need to wear it a little more during the day. What does that mean? They can wear it an additional 6 to 8 hours a day, indefinitely if they wish, without concern about posterior dental tooth eruption. That is the first question I always get when I explain to a dentist about separating the posterior teeth enough to get the load off the joint. And their concern is, and I think it's probably one of the main reasons, not the main reason, but secondary reasons why no one ever stumbled into the simple concept of just unloading the posterior teeth to allow the chronic inflammation to die down. The actual discovery was chronic inflammation drives all the symptoms. So you can treat symptoms, but if you don't treat the cause of the symptoms, which is chronic inflammation, and chronic inflammation being caused itself by the three types of damage to the joint, which is bruxism, acute trauma, and functional malocclusion. So device and the protocol are equally important. Stumbled into this because my patients kept, on investigation, interviewing, kept saying if I put my finger, my tongue, a pencil between my front teeth, a piece of cloth between my front teeth, and gently bite down, it feels better. A device was constructed of my own design that allowed the patient to speak, to swallow, and to drink hot or cold liquids based on my experience with orthognathic surgery and trauma surgery and cleft palate surgery. And the rest is history. But the protocol and understanding of the protocol and why the protocol is important and why it's important for both the practitioners, healthcare providers to know it inside out and backwards and why you have to follow that protocol. If the patient actually is following the protocol and the doctor is certain that they are following the protocol and does not get the response, something else is going on. If the patient is truthful, and the doctor has explained to them why they're doing it and what they can expect. What they can expect over once you put the patient into one of these is over the next 1 to 2 weeks, you will see significant decrease in painful symptoms. Inflammation dies down enough, usually within the first week or so, that they will experience significant decrease in painful symptoms. Now, it may not be 100% in 3 weeks, that's for sure. We know the numbers after 5,000 patients is 3 weeks. We expect the patient to say plus or minus 70%, plus or minus 70%. Some say above it, some say below it. But if they get a patient coming in at 3 weeks and they say, I don't know much difference, sometimes we just say, well, keep going, because that can't happen. But if you get the patient out to 2 months and they say there is no result, no, something else is going on. Either they are not using it, they are not being truthful, and I don't expect or look forward to the patient saying that, because I think our patients in our practice really want to be helped. The other two things that can occur and do occur with some frequency that alleviate the effectiveness of this device is protrusive habits, fiddling with the device with your tongue or your teeth, pushing your jaw forward. That happens fairly often, and you have to be able to recognize that and tell a patient to cut it out. And most patients actually do. It's very effective. Once you recognize it, while they're awake, they will cut it out. And apparently, while they're sleeping, they don't do it naturally. They do it. It's a habit. It's a volitional habit. It's not a unvolitional habit that they do while they're sleeping. Bruxing is, but protrusion is not. But a protrusive habit, or fiddling with it with their tongue or their teeth, trying to help it. See, I was just trying to help it. You don't need to help it. All you got to do is put it in your mouth and forget it. Is one of the reasons why we consistently see in those small number of people that come back at 4 weeks, 5 weeks, and say, I haven't noticed any difference. Well, you better look for a protrusive habit. And the other thing is, there are people who have enough muscle size and forces of contraction that just with the anterior 6 canine incisors can overcome that inflammatory process and keep the inflammatory process going, at which point the solution to that is simple, at which point the anterior pad, or the part of the anterior portion of the device hits only the anterior mandibular teeth, is extended, made a little higher. The device pad is made 1 millimeter, maybe at most 1.5 millimeters thicker, which increase vertical dimension, which puts tension or it lengthens the muscles of mastication, which is enough to, you lengthen a muscle and it decreases its force that it contracts. So you lengthening the muscle, the contractile force is less. At that point, the inflammation dies down because the forces on the joint go down. It's pretty simple. It is pretty basic physics at that point. Basic physiology if the patient has a protrusive habit constantly pulling the condyle out of the fossa. Now, that'll create some damage for sure if they're constantly have that anterior-posterior motion out of centric relation. So the protocol is very important to understand. One without the other is not effective. If you wear the device just when you want to, or you think you can wear it just when it starts to hurt, you're way behind the power curve. Now you're going to be, and then a patient will come back and says, well, I used it and it didn't make the pain go away. Well, that is why there is a initial part of the protocol that says 24/7 for 2 months. You have to give the device enough time, and everybody's a little different. I literally just crossed my mind. I had a patient years ago, doesn't happen very often, but a patient returned in 3 weeks, and she said, I put it in my mouth, I left her office, and by the time I got to the parking lot, it started to feel better. And that is why this all came about. Patients would say, if I put my finger, my tongue, a pencil eraser between my front teeth and gently bite down, it feels better. But just feeling better for a moment does not cut it. You have to actually decrease the symptoms completely. And these are just the painful symptoms that decrease rapidly: headache, earache, jaw pain, neck pain, upper back and shoulder pain, arm, hand, finger tingling, and numbness. Various kinds of locking, closed lock, deviation of the mandible, the constant complaint of my teeth don't meet together evenly. Those are symptoms of dislocation of the meniscus and lock. And those actually subside over a period of time, maybe longer than 2 months, often within 2 months. But because of the decrease in chronic inflammation within the joint, the synovial fluid gets less sticky. The synovial fluid under the influence of chronic inflammation, cellular and exudate of inflammatory cells, causes synovial fluid to become sticky. And that is one of the reasons that you get dislocation of the disc. The disc is sticky. The disc gets sticky to the surfaces of the rest of the internal portions of the joint, and the disc isn't pulled forward. The disc isn't pulled forward. It's pushed forward and stuck there because the synovial fluid becomes sticky. And as the synovial fluid inflammation goes away, then the synovial fluid becomes more naturally lubricant. And then the disc becomes less sticky and goes back to place. And we see that all the time. And of course, tinnitus, subjective hearing loss, and vertigo, they also diminish, but much slower because of the chronic inflammation cells, and more likely not cellular, but chronic inflammation exudates get into the middle ear through the petrotympanic fissure. So that's the explanation again, but again with emphasis on the topic of today. The device and protocol are equally important. One without the other, you can't expect the promised results. But if you are certain in your mind, and you educate your patient adequately so they understand in their mind that they must follow the protocol, they can't use the device just any old way, and that the protocol is equally important to the device itself, and that you follow them up to make sure that that is the case, you can expect patients to return within a reasonably short time, defined as between 2 months and 4 months, and say 90 to 100% of their symptoms, initial symptoms, are now diminished, decreased, or gone. 90 to 100%. We have a lot of 100%s. We don't actually discharge a patient and tell them to come back PRN until they say at least 85% to 90%, ever. So those are some amazing statistics, which are borne out in our Middle Tennessee State University study based on 3,000 at the time, 3,000 patients who got relief from using the device and protocol. Device and protocol. The device and protocol. It's that important. It works as a team. It was really borne out. Patients who would come in and they go, I'm only 30% of my symptoms are gone, and here we are now at let's say 4 months. We have a little talk. We find out what they're doing or what they're not doing. They don't have a protrusive. They don't necessarily need to have the anterior pad increased. You find out that they're not following the protocol. You get the patient to follow the protocol, and they come back in the next time they come back, and they will report a much, much higher response rate, which is higher response rate is equal to decrease in symptoms. I never ask the patient how much better you are. That is very, very difficult to objectify how much better you are. But it's much easier mentally for a patient to quantify how much of the, or how many, or how much of the symptoms are now diminished, decreased, or gone. And so we ask them to take all of the symptoms, lump them in a pile of symptoms, average it all out. Some of those symptoms go down at different, well, they all go down at different rates, and some of those symptoms are more important to the patient. Some of those symptoms that they verbalize in the beginning, well, they may have those symptoms, but they're not really important. Well, that factors into the patient's averaging out what portion of those symptoms are diminished, decreased, or gone, what percentage. And the patient will eventually, if you press them along enough, they give you one number, something between 0 and 100 at any point in time. At which point then you know how to direct the patient, and you know whether or not you're getting the response that you expect. But if you are not getting the response that you expect, which is significant decrease within the first 3 to 5 weeks, then you need to investigate for something else that's going on, because they're either not using it correctly, you don't have patient compliance, you need to increase vertical dimension, or they're doing protrusive habits. And it is clear in this practice that when you address the problem like that, then you can bring the patient back into having excellent results. I made my point. I hope this helps. I hope this encourages the providers, the dentists who are watching this, to tighten up their use of the device, those that are already network providers. If you're not a network provider, it's important that you take our course, because the device itself is patented. There's some legality to that you must, you can't violate civil law. If you do, you will generate some problems for yourself. But if you become a network provider and become licensed, you can use the device all you want and use the protocol, which I described in detail, and you can expect from each and every one of your patients excellent results as long as they themselves follow the protocol. With that being said, I look forward to our next episode. If you'd like to communicate with me, I can be reached at tony@tmjservices.net. If you would like to criticize me, I can be reached at tony@tmjservices.net. Just be prepared to define your terms and come in with some significant scientific data to back you up, whatever you have to say, because I have significant data to back up what I have to say, both individually and independent university study, which proves and validates what I just talked about, what I just discussed. I look forward to the next time. It will be a Tuesday morning. It will come directly out of Brentwood, Tennessee. I hope you have a great week, and I look forward to having you back at TMD Demystified next time.